ahead and get started. I don't have a microphone, but I have a loud mouth. Can you all hear me if I'm talking?
Oh, yes.
Yeah? Okay, great. Yes, I've never been accused of being shy. My name is Emily, and I'm the Respect Life Coordinator at St. Joan of Arc. And I'm going to do my best to MC this panel and to just help assist in the questions and introducing our panelists here. So we have 3 panelists, as was advertised. Starting from my left over here is Elliot Bedford, and he holds multiple degrees in philosophy and theology, culminating in completing his doctorate of Catholic healthcare ethics at St. Louis University in 2014. He has worked as Director of Ethics Integration at Ascension ever since, lives in Westfield with his wife and 4 children, attending Our Lady of Mount Carmel. Okay, so Elliot. And then in the middle we have Andy. He is an estate planning and probate attorney. Through his firm, Stouts Law, he helps people take care of the legal formalities of death and disability. Did I pronounce your last name right?
Yeah.
Okay.
And on a personal note, my wife and I are parishioners at Sacred Heart on the Old South. And we're expecting our first.
Yay!
Very, very soon.
Very
Anytime
soon,
now.
any day.
Yeah. And then last but not least is Dan Capes, husband, father to 3 kids, and a Joan of Arc Holy Rosary parishioner. He is also a board-certified hospice and palliative care physician. So what I had each of these gentlemen do in preparation for tonight, alongside many of the handouts you see here, I hope you all take more than you need and pass them on to others who aren't here tonight. But they helped put those together alongside providing a few different questions to just jumpstart our panel. We don't really have a huge format to this panel. Want it to be something that you all can lead, but in your questions. But just a few to get us started. So we'll start with a question on, let's see here. We'll start, I'll just go through their questions, one per. So for one of Dan's questions is, what's the difference between hospice and palliative care?
Yeah, so I'm board certified in both. The training is the same for both. There's a distinction. Many people, if not all, are familiar with hospice care, but not many people are familiar with palliative medicine. The main differences between the two are palliative medicine is for people with very chronic, debilitating, serious medical conditions over the course of that medical illness, regardless of their life expectancy. I take care of people of all different ages. During training especially, I help take care of infants and even families of premature babies, all the way to 100-year-olds and all different spans of chronic illnesses. And so helping families understand their illness better, helping them symptomatically through treatments and whatnot, that helps improve their quality of life, and helping them plan for the future, medically speaking. I don't do any of these things. But that's primarily palliative medicine. Hospice is primarily for those people who are nearing their end of life. Depending on the country that you live in and the government that you are under, the time frame is different. So here in the United States, hospice is typically for those folks that have a life expectancy of 6 months or less. In the United Kingdom, the last I remember, like in Great Britain, it was 12 months. So there's a distinction, kind of arbitrarily. But again, it's for those people with terminal medical conditions that really no longer want to proceed with life-prolonging treatments anymore and want to just primarily focus on their comfort and quality of life. Palliative medicine folks can be people who do have end of life or have a terminal illness like cancer, but still want to pursue chemotherapy, radiation, surgeries to prolong their life, but also have symptom needs or have emotional or spiritual needs in a clinical setting that palliative care can help with. So they're very, very closely intertwined, but there is a slight difference.
I would add on to that point from my lens and the ethics and moral lens. The important thing to understand about palliative care and in hospice is they're very good about helping you clarify your goals of care.
Yep.
So your goals can.
Speak up a bit.
Okay.
Yeah,
So
we're all old.
I can shout too. All right, I'll go with you. The important thing to understand about palliative medicine, hospice care, is their focus on goals of care. Okay, so with palliative medicine, you're going to be able to have curative or therapeutic goals, right? We want to take care of all the symptoms and symptom management. And we can pursue surgeries, and
We want to attain a goal that is curative or what I call disease modifying. That's palliative medicine. There's goals in that instance, and then for hospice care, it's primarily for my goals are comfort, or I want to live this particular way without medical interventions, I want to avoid the hospital system as much as possible, etc. And the medical care, so not only the medical conditions themselves, but the healthcare system is incredibly complex. And so a lot of my job is I'm a translator. I end up coming into a patient's room and talking to the family for a couple hours, just kind of unraveling all the medical jargon and helping families get a good idea of what to expect. And then what you want to do, knowing all that information, how do you want to proceed with life? And trying to take it less of kind of very short, myopic, tiny little, we're going to do this treatment at this time. It's, well, where do you want all of this to go? What do you want to get from all of this? And some of the most meaningful conversations I have with families are, I just want to be able to walk down the aisle with my dog. There's others, I want to see my new grandbaby. I want to be able to go play golf. And so it's, how do we get your medical care to do a certain goal or thing that you have?
Okay, so I'm going to switch a bit to a question that Andy had, is what happens if I don't do anything? So.
Yeah, I'm actually going to start with a little bit of legal context. I don't know where all y'all are coming from in terms of like sort of understanding where this fits in. The advanced directive that we're talking about is just a paper, I guess. It's a directive. It's telling your doctors, or telling your medical people in advance what you want to have happen. And so there are rules in the Indiana Code, that is our state law, that says what you can do with an advanced directive, with this document. And as Dan is saying, the medical field is really complex. The doctors have their own, goals, biases, usual ways of doing things. So the advanced directive is just kind of a document that you can use to kind of make your wishes known in advance, especially if you're worried about getting pressure, or you've got really important end-of-life teachings, religious tenets. It's all something that can kind of go into this. So, sorry.
No, and I was going to ask you, is there a distinction? So when you say advanced directives, is that, my patients ask this all the time, is that like my house, my car, my assets, what happens, or my funeral planning, or
right.
Is it that advanced directive, or what kind of things?
Well, I'm an estate planning attorney, so usually when I'm seeing people, it's because they're thinking about their property. They're saying, okay, who does my money go to, my house, all this. And the advanced directive is kind of an extra to a lot of clients. They're not thinking about it when they come in.
Yep.
And I tell them, hey, this is part of your complete plan, because it's before you die, before we're giving your property away. How do you want things to go? So that's kind of the context. Most clients are thinking about money first, and then health later, and then later you hear from them. Right, and then later you hear from them, and it's like, oh, I was really glad I had to, but that turned out to be more important.
As a physician, I find that when I talk to families, they've already completed their estate, their funeral arrangements, their plot. They've done all the things for after they've passed.
Yeah.
It's the things up to, and how do you want to direct this very complicated medical issues of your life up until then. And it's surprising how many people don't get that counseling.
Yeah, so it's usually part of that conversation. It can be separate. I heard from a practitioner that some places, you work in a Catholic hospital, are giving a blank advanced directive form to patients when they come in. to say, like, especially if you're undergoing a serious surgery,
Yeah.
it's like, well, write it down while you can.
Yep. There are, and I'll speak from my experience, there are times where that's helpful for patients and families who are very well informed, much like you will all be after tonight. But there are a lot of families that get that without any counseling or guidance. And so it can be problematic if you don't have an interpretive lens with a provider or practitioner to go over it with you.
Well, I'll speak to that point in terms of my knowledge of, I'm thinking of a chaplain specifically so what would happen in a situation where somebody's coming in for a coronary, like a stent, putting in a stent, right? They would say, all right, we're gonna put you under for surgery here. Is there anybody that, if you're not able to make the decision for yourself, who would we go to? That is an advanced directive of designating somebody to make a decision for you, right? And I would recommend that we leave today with, I'm going to document who that person is, and I'm going to have a conversation with that person about what I would want. That's something as Catholics we have a responsibility to do, quite frankly. So that level of conversation about advanced directive and it being handed to you at the point of preoperatively, very much in support of. If it is kind of like a left to your own, check the boxes and we'll document it.
Kind of getting to the nitty gritty of specifics.
I would say that would be not the best context for it.
Yeah.
But in terms of making sure that we all know who to go to for making your decisions, absolutely we need to be able to have that on file because stuff happens.
And so what would happen? This
Yeah,
would go back
so
to you.
now
What
we
would
can
happen
circle
if
back to
you-
Emily's question.
Oh, I
Good
had a
question.
question. I did that about 15 years ago. I had a procedure and they said you have, and I filled out the old one of these
Yes,
and I had
big
all
one.
that, what do I want, whatever. And then I gave it to wherever that clinic was.
Yes.
I had no idea where it went.
I bet you
had no
they don't
idea.
either.
I've
They
got
probably
all
don't
these doctors
either.
now and I
They,
don't
mean,
know.
and Dan can
probably
speak to it,
it's
yeah.
probably been shredded and gone
See,
and
So I need to do it with my family,
you
don't I?
need to do it with your family
Yeah.
and you need to have the original copy. That's what
I
I do
do
with
that.
all of my patients. We complete it together and I give them the original, plus I will give them lots of copies. And we'll keep one copy.
Yeah,
That
they
thing gets
always
scanned.
ask me if I
Do you have
am in
one?
for something, do you have an advance directive?
Yes.
I say yes, and that's it. But I have no idea.
On the back end of that, just speaking from the health systems from the inside, they're going to continue to ask you that, but unfortunately, it's not like I put it into the system once and it's everywhere. They're going to.
We don't, our systems don't talk well with one another.
Tell me about it.
And so unfortunately, as a
We should have
doctor,
brought our PR people.
yeah. But what I tell families, unfortunately, when it comes to these documents, it's really your responsibility to have them. It is something to be a good steward of yourself and of your situations. A lot of that is on the patient and the family to do that. There is no database, there's no thing like that. We'll do that we'll have a database for opioid prescriptions or we'll do that for some controlled substances and whatnot, but we don't for advanced directives. I'll tell you there is a slowly gaining traction for a database for advanced directives, but it's very slow.
It's interesting to hear. The law contemplates, like, you give it to your primary care physician and it's in the master system. So it's interesting to hear that.
No, there unfortunately is not a master system.
Operations are a different thing.
Yeah.
Would you recommend bringing like copies to every physician you go to, within reason?
I do, yes, within reason. Yes, and that's why I give my patients, like when I fill it out the first time, I will give them 5-6 copies, especially one for your original, some for your children or your healthcare representative, and then you can make copies of it from there on out.
Andy, at some point you'll get to talk about the topic you said you're going to talk about, but I have another question.
Yeah, sure.
What is the overlap between advanced directive and a medical power of attorney?
Good question.
The advanced directive law got rewritten in 2021, and it was a great simplification. Back in the day, there was a living will, and then there was a life prolonging procedures declaration.
Living will declaration.
That's
something.
what I
But there were two, and they were different based on whether you wanted life support or not.
Yeah.
And then there was a medical power of attorney.
I'm glad I didn't
Now,
practice those.
right, now, there are just healthcare advance directives, and there are financial powers of attorney still.
Yep.
But the law strips the effect. If you try to put healthcare powers into a financial power of attorney, in theory, who knows in practice?
In practice-
In theory, the healthcare powers that you put into a general financial power of attorney are ineffective.
I will say when I just recently had a case, I think if you filled out, so, how do I do this from a practical standpoint? When you think about planning ahead, you have to think planning ahead, as we mentioned earlier, financial, estate, things, and then medical. The law now has completely separated them where you would have documents that were all the same. I had a case where a patient had completed where it was all together, and according to our attorney at the hospital, it was completed before that transition, so it was still valid. So if you have a combined one that was after
Supposed to be
2021,
grandfathered in, but
Supposed
no
to
new
be.
ones.
yeah, but no new ones, and so that came into effect. So just know the law, for you all, the law was simplified to, it might be a little more complicated on the understanding end, but in a practical sense, it's very helpful.
I would say from our perspective, it was definitely a helpful simplification. It prioritized healthcare representatives, right? Documentation of healthcare representatives, which is what I was just talking about. Simplified the form. I agree, the form used to be a response to a case that was, can a patient refuse nutrition and hydration? And that's what the law was responding to. It was very limited. This opened it up and said you can make choices about limitations or requests on whatever, but we need you to specify, especially if you look in that the Indiana Catholic Conference document, it talks about healthcare representatives being the most important thing to touch on. So very, very good advancement, and it's an update to the appropriate kind of like, it fits better within the system now
Yeah.
than this old tool.
Yeah, and I think I want to get to the question that Emily posed to Andy, because we highly recommend naming a healthcare representative, but I think to kind of wrap that question around, and we'll come back to your question, I promise, is what happens if you do not name a healthcare representative? Because that does happen very frequently.
Right.
And there's a section in the code that deals with that. And it gives you just a list of people in order of priority. So it's, your healthcare representative if you've named one, your judicially appointed guardian if you have one, and then it kind of goes down, spouse, adult child, parent, sibling. Very bottom of the list, which tickles me, is 10. The individual's religious superior, if the individual is a member of a religious order.
Which the first
You
thing,
only get there if there's no other.
which is very interesting, because one of the first things that you do when our seminarians become priests, one of the first things they do at a ripe old age of 20s, 30s is, talks to the bishop and goes, who's your healthcare rep? Let's talk about your medical stuff.
Oh, okay.
They do that very quickly, because bishops don't want to
Right.
they don't want to do it. So yeah, and part of my job too is I get consults in the hospital all the time. Well, who's the real decision maker?
Right.
Who is the real? So, for many people, it's usually your legally married spouse, and then followed with your adult, greater than age 18 children. After that, I have to then look at the list myself to see who fits out.
It correct me if I'm wrong, but it does. So you say you get into your kids category, and you've not named somebody. It doesn't. If you've got 3 kids, it doesn't determine which one of your kids, right? So it's kind of a cage match, and
Yep.
whoever wants to or doesn't want to.
Simple majority.
So then, you want, this is again, I want you to think of advanced care planning, the advanced directives, all in terms of how can I provide peace of mind. That is the overwhelming message here.
And I will tell you that you cannot imagine,
Right.
and keep asking.
Yeah.
I think a lot of times families will feel like, they're not talking to me, I just can't get anywhere. And they unfortunately, families don't have the power. I'm very happy to have that specific conversation. And I think that's the beauty of the church's teachings when it comes to nutrition, hydration at the end of life. It's very individualized for the person.
And it's also, so it's individualized, it's also contextualized, where it's a thing of, we don't, not just because I said it in the advanced directive and therefore we're gonna do it until the end. No, we're always called to reevaluate in light of changing circumstances. And I think that's something that I've run into a lot, is families want to be true to patients' wishes, but don't necessarily understand, well, when the patient was admitted 2 weeks ago, they were at this state, and now things have progressed,
Yes.
and we're at a different state.
There's so many, I love advanced directives, I do them every day. I love them. Unfortunately, there are thousands and thousands of different clinical scenarios that doing an advanced directive is sometimes actually not helpful. We want you to be able to have that conversation in the moment. And I think having conversations with your person that you trust about big general principles is more important, and then you can then get into the conversations and nitty-gritty with providers.
That's actually what we end up doing in practice. I mean,
Mhm.
if you look at the law, it says, here's things your advanced directive can do. You can
Mhm.
name a healthcare rep. You can make a list of treatments you want and don't want. You can make a mission statement, like in the back of that.
Mhm.
In the back of that booklet, there's like a sample one. It's got Catholic statement of faith and mission.
Mhm.
You can do that. You can disqualify someone from the list, which is, a senior practitioner tells me, the most common thing people request is to scratch someone off the list, more than anything else. Anyway, so it's infinitely flexible, but in actual practice,
Mhm.
it's like, you know what's better than trying to predict everything right now and putting it all on this piece of paper? Going to talk to your people
Mhm.
so that they
And-
know.
And you'll even notice, I brought the pink form, the Indiana Post form. It's physician orders your scope of treatment. It's somewhat specific in certain aspects, but it's also vague in other aspects. And it's not, I tell my patients all the time, this is not legally binding. It is a guideline for conversation. And it's something for your family to have, for the doctors to have. And it's helpful in an emergency situation for providers to know your general principles. Like, I do not want CPR, I do not want life support, I don't know what I want for feeding. That's helpful to act in the moment. But it's such that it can be verbally overridden by the patient and the patient's healthcare representative. So whatever you say or your trusted person says, you can rip that paper up, doesn't matter. It's also super helpful so you don't have the same conversation every time you see a provider. It's helpful to go, these are my general ideas of what I want. And they go, okay, great. I know where we're starting from. So I don't have, particularly for me, I don't have to start from the beginning about your medical wishes. That paper or your advanced directive gives me an idea of where you're at. But again, as Dr. Bedford says, it's very contextualized to the current situation that you or your loved one are in medically, and then also individual to that person, their preferences, beliefs, desires, wants. And so have a conversation. I'm very open. I get to practice at a Catholic hospital, and I love doing that. And so the church does not impose feeding on people to their end of life. It doesn't impose that. You're not obligated to feed. Now, offer food in a simple form, either by hand, what a person will take, that is obligatory. But to do it in a medical intervention is not fully obligatory unless that's what the patient wants.
I think that would be a nice segue into the questions that you brought in, just speaking directly from the Catholic perspective. And
Any more specifics on that you wrote down? I mean, I can pontificate lots, but,
well, I think it will bring up some questions as we go. So how
well,
about-
the first thing I would say here from the church's teaching perspective, and putting it into practice, is the best thing that you can do as you're reflecting on all of this is to start thinking about those general things that you value, right? You mentioned, like, I want to see my kid walk down the aisle, I want to see them graduate, so on and so forth. That level of reflection about what's important to you in your life right now or your loved one, that's where you need to spend your time. Don't worry about all the possibilities of this medical intervention or that medical intervention. Talk about what's valuable to you. Have the conversation with your loved one who's going to make decisions on your behalf. Because then that gives our teams the goals for, all right, we either have the medical technology to be able to get them to that place, or we don't.
Or we don't. Okay, so that is palliative care in a nutshell. And we do it within the context of patients with chronic medical issues, heart failure, COPD, cancer, dementia, on and on and on and on. My conversation, I love my job because I don't get to talk medicine for the first half of a visit. It's like, how are you? You know, is this your spouse? How long have you been married? How many kids do you have? What do you do for a living? What do you like to do? What's important to you? And I'm trying to draw out from you those wonderful things.
Can I finish my question?
Yes, ma'am.
We didn't get a chance to ask any questions, I don't know, of course, it's too late for me, my brother's already passed away, and, he had all those legal papers, and every time we went into a hospital, nursing home, they wanted us to start all over again. He had 4 to 6 months to live, and, he went into a spell on Good Friday, and he got his last rites on Saturday. He came back into it, but he went back in kind of a coma or something. I don't know what happened to him, and he wouldn't eat very much, and he didn't want tubes in him. But I have a horrible feeling, that he was starved and dehydrated to death. He died on April the 28th, and tell me he wasn't.
That's going to be hard. I was not there, nor am I a physician. But I would say that the idea of, and again, so I could kick this over to medical practice, of being able to understand what the dying process looks like from the physiological standpoint is something that it is, there's a lot of learning curve in there. Every patient's different, but
And
speak to that.
And Mary Jo, you and I can talk a little bit more.
Well, he had less than 2 weeks to live when he got in Aldenheim.
And you and I can talk a little bit more after, because I know I helped with Steve's case.
Okay.
But to give you all an idea, in particularly in the developed world, first world countries, U.S., Western Europe, etc., it's incredibly hard to die of starvation, dehydration. It's just as, particularly in the United States, where many people are overweight. You would be surprised at how much water is in your fat tissues, and so it. We'll save those comments for another time. And so it's very, very hard. Many people, the reasons why they will pass is most people will really relate it to an infection. Most people. Some type of your process will lead to a skin infection or a bladder infection or a pulmonary infection, and you'll pass from an infection. There are a small number of people where they will have some dehydration that leads to kidney failure. When it comes to symptoms related to starvation, dehydration, in my experience, it's very exaggerated. Not many people experience terrible pains, hunger pains, or thirsts at their end of life. They don't. You'll notice this if you've ever had a loved one with dementia. And you're like, how, they're not drinking, they're not eating, how are they not complaining of it? Like, they're not in pain, they're not hungry, they're not, especially these very, very tiny little old ladies that are this big around. Yes, we have those drives of thirst and hunger as we progress in our chronic illnesses. They aren't there anymore. We don't know why. they just don't have those drives for thirst, they don't have those drives for hunger, and so you don't have things like hunger pains or thirsts.
Can you clarify though that I think that's a very generalized statement, and having been in the room with someone that was going through that within 1 week of dying, I did see that thirst, and I was feeding. I remember, from sips of water to ice chips to just, a drop
The
of water.
biggest,
Are you talking like the 24 hours of death, the 48 hours? Because that's a pretty broad.
it's broad, it depends on the person.
Yeah.
I will tell you, that symptom is predominantly related to their salivary production. And so a lot of what they're complaining of is more dry mouth rather than actual thirst. And so yes, that is actually one of the things that we teach our families at their end of life, particularly with food and water, is continually offering ice chips, continually offering sips of water, continually offering, they do make artificial saliva, it's not, and so, yes, that is a true symptom. And actually, many of the medicines that we give for comfort at the end of life, one of their side effects is dry mouth. And so, yes, you are correct. But the actual, that sort of innate thing in you where you're thirsty, that's not there. But that sensation, that dry mouth, yeah, that's awful.
But excuse me, that my brother had that dry mouth, and then when they tried to put liquid in there, he couldn't swallow, and then he would end up with that, what do you call it?
That gurgle.
The gurgle. It was just like gargling. It was terrifying.
And that can be that's one of the difficult things when it comes to caring for someone at end of life, is even some of the most basic beneficial things do start to become burdensome. Things like nutrition, things like hydration, where their ability to take those things in is diminished, and trying to give it to them hurts them. A lot of times for families, that's where the artificial saliva might come in handy, where we don't want to give them sips of water because they can't then swallow it. That's where we do a lot of things like lip balms. That's where we got sticks with sponges on them, and we kind of coat them out. And unfortunately, someone's care at the end of life, the person at their bedside matters a lot. And so no one takes care of your loved ones better. No one takes care of a dying person than their family. And so that's one of the disadvantages to things like nursing home care, is they're not your loved one, they're not as committed. And so the amount of time, it's very simple to just wet someone's mouth, but the amount of time that they will spend with them, it can be variable. And I know that can be distressing to a lot of families. I know. And a lot of times, and this is very specific to the loved ones, to the dying person, is they aren't able to tell us what's bothering them either.
No.
And how do you determine how they're bothered? It's very much an exact science and very much an art. And we really have to go on a lot of nonverbal signs and cues. And it's hard.
There's a little medication in there that dried up the gargling and stuff, and that was a relief, but it would come back again. So.
It does, and there's a lot of specific things there, Ms. Fussell, that you and I could talk about later.
Okay.
I'm very happy to do that.
Okay.
Yeah. Does that, I don't want to come back around to.
If we're talking about Catholic medical ethics, I got a question, because I write these for clients from all different backgrounds, and are there any and like I said, in practice, it's often better to leave things a little flexible and depend on conversations and our own people. Are there any Catholic teaching, red lines, things that you do definitely want to see or not see, in a care plan for someone who's committed to following Catholic teachings?
Sure, I go back to the principle of designating who you want to make your decision when you can't speak for them, for yourself. It's not like a mandate, but it is the most prudent thing that you can do. with regard to specific interventions, the teaching is beautiful in its flexibility of between ordinary and
Is
extraordinary.
that foundational to you?
It's-
Do you think that's like the
That's the
basic?
thing, and let me put it into practice, because the church puts out those principles, but really what it is saying to you is you as a patient need to be evaluating your circumstances, all the dimensions of your circumstances. How much is it going to cost me? How much is this going to take me away from my family? How much is this going to be, what's the pain level that I'm willing to tolerate? You need to be processing those burdens and benefits to be able to make the informed decisions along the way. So what you're going to do with Dr. Capes is you're going to be having a conversation, and he's going to ask you questions that are going to help you articulate what your extraordinary or ordinary means judgment is.
You get to decide extraordinary to ordinary.
But the way that you do it is this questioning of like, all right, well, do you think you could tolerate that? Do you want to try it for a couple of weeks? Do you not want to? That's all the
Yeah.
church is teaching in practice. Okay, so the idea of having those conversations, and what I see as Catholics is, and it's not unique to us, but the idea that, well, end of life is not a fun topic, so let's not talk about it. Let's not, let's just wait until the time comes, and then we'll deal with it. No, memento mori, that remember we're going to die, is a very important principle that basically we should be talking about since when we're 18.
Yeah.
So the idea of making sure that your 18-year-old has an advance directive that appoints people to make decisions for them, that's a prudent thing to do. So those are things that I would say, like, we really should be having those types of conversations. And honestly, to Dan's point earlier, the church's teaching is absolutely beautiful, okay? And when you follow it and let the Holy Spirit into these situations, it is profoundly transformative. I see the grace that's in those situations, and families come together, they overcome fracture. I've seen situations where it's the exact opposite, where there's fighting, there's animosity, all sorts of stuff. The church's teaching says death is a reality that we need to deal with, okay, and I want you to make those decisions in light of hope of salvation, and so you're empowered to be able to talk about these things freely. So have the conversations about what's meaningful to you, how you would be able to, kind of navigate these things, and don't have it be a one-time only conversation.
It's an ongoing thing, and I find that the church's teaching is very beautiful in its allowance of free will.
Yes.
It very much is an allowance of the individual's free will, and you get to decide what is ordinary, extraordinary, burdensome, helpful, with the aid of a good provider.
And here's where I would add on to
Add,
that.
yeah,
I would
please
add
do.
on to that. So a lot of people are going to, people will ask me, Ellie, I want to do I want to follow church teaching in this situation. I want to, and I want to do it right. And they come to it from the perspective of, this is a test that I gotta pass, right? And I don't want to fail it. And I'm going to say, the church's teaching and the whole premise of the church is more about relationship. We're in a loving relationship with our Creator and Savior here. And so you need to be making decisions in light of that loving relationship. Of, am I trying to cling on to some lesser good here? Like, my life is a good thing, right? He gave it to me. But am I, clinging on to it, trying to preserve my life at all costs? Okay, well, if that's the case, then I need to reevaluate, because that's
Well,
not loving God
and-
for His own sake.
And I will always say, well, what are you preserving your life for? We have to have a reason. We have to have reasons for why.
Right.
I will get there. I like and I don't like the battle warrior fight terminology with cancer.
Right.
I love and I hate it, because if you're not fighting the cancer, you're quitting. Well, that's not true. It's in your medical care in the context of your cancer. What are you fighting for? What are those things of, why are you fighting the cancer? Who are you fighting for? A soldier typically is fighting for a cause in front of him or the people behind him. And so why are you doing it? I think that's versus allowing death to happen naturally. allowing death to happen naturally by not having an intervention, by not having a medical procedure, that is very okay with the church. You can allow that natural process to happen. That is not the same thing as suicide. Suicide is the act of killing someone. Foregoing medical interventions is allowing the body's natural process to take effect. And so that is not suicide.
So, just to take that a step further,
Mm-hmm.
if if it's not that clear, so factor out taking a
Medicine.
killer drug,
Yeah.
factor that out, but this person could likely live, but they're telling you, nah, I don't want that. I don't want that surgery. Well, you know, Joe or Bob, you know, you've got a good shot. You know, this is a 70-30 or something. You could make it through. And I'm just wondering whether the landscape is changing because of all the crazy states that are letting people kill themselves. Are you encountering, you know, more ethical issues where people feel like, well, wait a minute, maybe the right thing to do is not have the surgery. And how does the church
So
deal with that?
Speak to that one in terms of so if you look in the countries like Belgium that have had long-standing
Yeah.
assisted suicide laws, you've noticed the development of a social pressure around making use of that, right?
Canada is now
Right.
doing it very
Right.
rapidly.
So you get this uptick because there's this social pressure of, well, I don't want to be a burden on my family, yada, yada, yada. So I would say that I would still distinguish that phenomenon from the idea of, I'm looking at this chemotherapy run or surgeries and it's too much for me.
Yeah.
Mhm.
And-
That one, I haven't really seen a big change,
No.
uptick, all that kind of stuff. And again, that's legitimate for you within your
And-
freedom. The other piece, I can't speak to Oregon, I can't speak to Idaho.
And you can, the hospital ethicist or physician or brother or, you know, can say, hey, wait a minute, you
Yeah.
kind of like, you can't do that. I mean,
And so
you know.
I do have some of those conversations in the reverse. I always find it great because sometimes palliative and hospice can be misconstrued to persuading someone to stop medical treatments. My favorite thing is I'm like, hey, that might be a reasonable thing to help you gain your goals, and doing treatment might actually be beneficial to you.
Yeah.
When I encounter a patient that does happen, again, it's another conversation about, well, why? Why would you not? You know, if the odds are this way, you know, and it could benefit you in this way, well, why not? Well, I saw my dad and my mom with chemotherapy and it was awful, so I don't want to even try that. Or, one that's very common that I see many, many times is Jehovah's Witnesses and blood products. And so a religious belief. So one of the very first cases that I had as a trainee was with a Jehovah's Witness, and it was one of the cases that prompted me to do hospice and palliative care. The patient could have survived many years, but because of their religious belief to not take blood products, they did pass away. And so there are religious reasons why someone might not choose that. There might be prior life experiences, either themselves or with family. There might be misconceptions, and it's, oh, no, that's not what you're thinking about is not correct. You know, these side effects are rare, or they can be treated, and our cancer doctors are getting really, really good at treating the side effects of chemotherapy. They're getting wonderful. Chemotherapy has not changed much since the 70s, but how we treat the side effects has gotten much, much better. And so it's it's another conversation. And sometimes that's where I then get into conversations about their mood, their thoughts of worthlessness, guilt, because depression can be a very big driver with patients with chronic medical issues. And so if they start believing that they are worthless, they're no good, they feel guilty, they're like, well, I don't deserve to live. I love that part of my job too, is because I get to say, you're a beloved son of God.
my case is a dear friend who's an old Marine, and he got to the point where it's just like, screw it, I don't want to live that way. Well, even though we were like, wait a minute,
and
you could
sometimes-
though. You know, he's
And to his point, I didn't mention this either. Sometimes, yes, treatments can help you live, but in what circumstance?
right.
And so if it's not the way that you want to live, say, yes, you'll live, but you'll be in a wheelchair for the rest of your life. I don't want that.
Right.
That is permissible. That is too burdensome. Even the positive effect is too
The
burdensome.
church would be okay with that?
I
Like
don't
said,
think that's
like
really.
case by case.
It's
in
case by
terms
case.
of- In terms of the patient being well informed,
Mhm.
and then, because you run up against this point of, okay, the patient's making their decisions. At what point are we willing to compel them to do something against their own wishes,
Yeah.
right? And so, receive a surgery or go to dialysis or something like that, you run up against this kind of like assault and battery line.
Mhm.
Not in every case, I'm just saying that there's
Yeah.
practical
It's-
realities that you're dealing with.
I can see what they're saying. So I just, friend of a friend just had meningitis, and within weeks, you know, I guess the medication has to protect your brain, and so it cuts off circulation. So within weeks, he became a quadriplegic. He had to have all 4 limbs amputated. And I think to myself, would I go through that? So I get what you're saying.
And again, it's case by case basis.
Well, this guy is a mile away from that.
Yeah.
And he's saying, I don't want any more care.
And
I want my-
sometimes, and that's where my conversation, it's not the form of compelling, it's the form of, have you really thought this all the way through?
It's kind of a moral persuasion.
It's not necessarily moral persuasion, it's, have you the phrase that got me, that is like, you're military, but all you had to say was military, and I know exactly
Yeah,
the type of
that's
person you're
him.
talking about. And so, that informs a lot. And so that's where I come in palliative care, and just have a really long, wonderful conversation about, tell me why. You know, I'm here to help you understand this better and what you find is appropriate for your situation. I had a case of a young woman a long time ago that she had a terrible burn related to a medication called Stevens-Johnson syndrome. She had to have both her hands and her feet amputated. And she didn't make any of those decisions, her family did. And one of their worries is what is she gonna think when she wakes up? And you know, that's another, is living in that way, even though it's living, is that what I'm called to live?
Would the church okay if let's replay that, she's awake, she says, no, I don't want that, I'm not gonna live with no hands and no feet. Would the
We
church
can't.
say okay with that?
We can't compel her to do that.
Ultimately, so, and that's where you say, in terms of the relationship.
Yeah.
with God, she's working on this relationship
Yep.
with God, and she says, the burdens associated with living under those conditions are too much for me. We don't have the capacity to be able to
It's
step in and
Very
adjust.
similar to, and this just.
So if she's taking active measures to end her life,
Yeah, that's sure.
that's a different story
Yeah,
in terms of making the
There-
judgment.
yes,
Yeah.
sorry,
Go ahead.
I get so jazzed and excited. And that's where I need to probably maybe change the words that I use with families, but I think, as Dr. Bedford said, it's that kind of relationship with God. It's like, what is God calling you to in this instance? Is God calling you, hey, is it time to come home? Is it to come to the Father, it's time to come to me? Or is it, no, I still have work for you? You know, it's that conversation with patients and families about, is that what God wants? It's truly, God does not, you're a theologian, right? Okay. God does not, even though that death is a fact, suffering is a fact, God does not compel us to choose suffering. We don't have to choose suffering. Suffering will come upon us, but if presented with suffering, not suffering, God does not make us choose suffering. We can choose not to suffer.
You can die from the disease.
Even if the
Like
suffering,
diabetes, yeah.
even if the suffering is likely to keep you alive.
Yeah.
That's my
Yeah.
questions,
Yeah, I'm
is
hearing-
where is the church drawing a line here.
So the church's line is at the level of principle. Like I said, ordinary and extraordinary means proportionate, disproportionate. And so then it comes down to you, or your buddy, honestly and soberly reviewing all of the likely outcomes and what it would take. So for instance, you might have the same person or multiple people in the same exact scenario and have multiple different outcomes. And it would all be consistent with the church's teaching.
Okay.
So you could have.
It's that level of freedom
Yeah.
and responsibility of the individual patient to do the evaluation.
You could have 5 different choices, 5 different outcomes, and all 5 can be okay.
Yeah.
I think
I
he'll
think,
be glad to hear that.
I think and not to speak, I think what I always recommend to patients and families is talk with the people around you who know you well, because sometimes they know things about you that you don't know about yourself, and get their opinion, but then also encourage.
You guys, like, does the hospital?
That was
how do
one
you-
of my
How do
questions.
you
I
get
was
one of
about-
you guys
I was
to
about to
That was
go?
another one of my questions.
You know, if I'm in the hospital, I'm not gonna make it. Do you come to the family or just?
So, unfortunately, well, ideally, let's talk about ideal. Ideally, if you are someone who is struggling with a chronic medical illness that is affecting your ability to proceed in life, it's getting in the way of the things you like to do, it's getting in the way of the things you need to do, whether around your home or even for your own well-being. That's an instance to have a conversation with your primary care provider and go, or the specialist that's helping care for you, so your heart doctor, your lung doctor, your cancer doc, etc., and go, hey, I'm starting to really struggle in these areas. I think I might want to talk with palliative medicine. And they would make a referral to us. And most of the hospital systems, no, all of the hospital systems in the city have palliative care departments. Some of them have better clinic presence than others. So that's the ideal, is that you would see palliative medicine in a clinic when you're struggling but you're not near death. Very, very far from death would be my hope. One of the things that Dr. Bedford and I were actually talking about this earlier. Unfortunately, the modern American healthcare system is very reactionary, and so many people will only start to talk to palliative medicine when they're ill in the hospital. And that's either because the doctors that are taking care of you are worried about you, or you yourself are like, I'm not doing so well, I need to talk to somebody. So that's another thing. You can ask for palliative medicine in that instance too, from that medical provider. So you can't, unfortunately, you just can't walk up to the palliative care office and go, hey, I want to be seen. You need a referral, unfortunately. There are, the problem with a lot of the healthcare system too is we don't have as many, we don't train enough hospice and palliative medicine doctors, so there's not very many of us. And we don't have a lot of the resources that we need to be able to care for patients. So my practice is predominantly in the hospital, but at Franciscan we are working on getting in the cancer center clinic to help take care of palliative care needs for cancer patients there. We do have a home-based palliative care program, so for those patients who aren't able to come to the doctor, we have some nurse practitioners and other programs have this as well, where they go to the patient and family and assess them at home and have these conversations at home. So that's either home-based or what we call community-based palliative care. I know community has it, Franciscan has it, IU has it. Unfortunately, no. There's a lot, and one of the things, if I ever get something, I'm going to send it to Emily and have her send it through the e-blast. If you ever get anything about let's have more unfortunately a lot of these things are government provided, either through Medicare and whatnot, and so Medicare has provisions that they will pay for certain things, but only to a point. And so lobbying your state legislatures, your congressmen about more resources for hospice and palliative medicine, but then also just asking for it from your primary care doctor and asking it in that way, hospital systems will start to listen. Palliative medicine, we don't really make money. that's the problem with hospice and palliative care. We actually, we have a hard time paying for ourselves. So a hospital system that's saying, why should we grow and develop your program if you're not making money? And so that's part of my job, is to go to administration and go, hey, I'm doing really good work. I'm saving you money on the other end. There's just a whole other conversation. This is good for patients and families. I would love to hire a nurse in the clinic. I'd love to get an MA. I'd love to have a scheduler. Can you please help me get those? And it's hard. So.
But are you covered by most insurances?
We are, yes. We are covered by most insurances, just like another subspecialist. So, like your copay for your cardiologist should be roughly the same for palliative. Yeah, it should be the same. It's like an outpatient visit. But the infrastructure, the clinics to go to are, but we can help you find something. So, I'd love to see more people in clinic and love to see more people not in the hospital. Because a lot of what palliative medicine can do is keep you out of the hospital. Maybe you don't want to come to the hospital if you have an issue with a chronic medical issue. You know, gosh, going to the hospital, getting needles and prods and getting woken up every 4 hours and not having any freedom in the hospital, and that is not for me. And we can help guide you in that way to keep you out of the hospital for as long as possible and to stay at home as long as possible. And so there's a benefit starting palliative care very far upstream. It's my fight to get hospital administrators and others to agree with that. So.
I do want to be mindful for everyone time-wise. We are at just about over an hour. So I think we'll do maybe 1 or 2 more questions and then close out with a prayer. But I think this has been really fruitful conversation. I hope you all have been able to get something out of this. Does anyone have any lingering questions that might be good for the broad perspective?
I was getting that advanced directive information from my spiritual advisor, and I called him and he said, I'm working on it, I'm gonna get the best one for you. I don't know what that means. But now he left, and I don't have the advanced directive, and I don't have a spouse or cousins or anything. So I don't know.
Do you have a primary care provider?
Yes.
Okay. I would recommend going to them because they can help you with those things. When it comes to, now we'll get to legal stuff. When it comes to naming your person, who your healthcare representative is, you can do that through an attorney. You can also do that through the documents that we provided, and you can either do it with a notary, so someone who's a notary, they can do that, or 2 witnesses that are not the people you name, or anybody closely related to you.
A couple practical points there.
Yeah, and please correct me.
One, there are notaries at most banks. So usually if you go into your bank with a piece of paper, you can notarize it. So don't be scared about that. Second, it's technically the unauthorized practice of law for someone to say you should use this form and not this form. But we don't care, because this is something that the law is designed for this document to be DIYable, because everyone needs one.
And you'll notice there are you'll even notice between the document that I gave and then the one that's in the Indiana Catholic Conference, is slightly different. There's some nuance, there are some things that are slightly different. The general thing that you want to avoid is, let's say, I name my brother as my healthcare representative. I don't recommend him being one of the witnesses to sign it. So the people that you name, don't have them sign that. And generally, I recommend not having family be witnesses either. They're a little too close. So that's why I love hospital chaplains when they go and talk to people. Hospital chaplains are very unbiased. It's like, hey, who do you trust to make your medical decisions? And you say, oh, I trust Bob and I trust Bill. And you put Bob's name and Bill's name and their phone numbers. Chaplain will sign it, and he'll have someone else witness it. Done. It's
So
very
you can
practical.
do it through the healthcare system. You can do it yourself if you can just read some forms. The state, in the law, the state says we're going to create an advance directive resource center. It's on the state website. It's got.
Wish I brought that stuff. I wish I brought that stuff.
Yeah. And so there's that, or you can go to an attorney. Like if you're doing your estate planning, every estate planning attorney should probably at least talk about it. If not, put it in with your will or
And
whatever else.
I'd love to get your perspective on the medical will, because I find that I really like, so the pink form, the Indiana physician order for scope of treatment, is more practically helpful than many living wills. And Dr. Bedford can help. It's easier to interpret as a medical proprietor in a hurry. And so I wonder if, go ahead.
Let's talk about that.
Yeah.
So advanced directive we've been talking about is a general form for your patients, for people to understand your wishes into the future. The pink form right there, the post, that is a standing physician order. So it's not technically the same as you writing your wishes on a piece of paper, because what that does is if the EMT ambulance comes out and sees that, and then they implement the physician's orders.
Yes.
So it's meant to be transportable between institutions, because we recognized, hey, well, what happens, I'm in the hospital and then I go to the nursing home. When I'm at the nursing home and I have an issue and I don't want to go back to the hospital, how do we make sure that that stays out? That form is a tool that helps ensure that the physician's order is carried out. With an advanced directive, otherwise, you have to translate the wish into an order to be able to implement it. So
And
it's a more effective, but I'll say it's narrowly limited into you have to be eligible to have one, right? It's statutorily defined, and that there's this is
That's actually on the back page.
right.
So to be a candidate is section H.
You're right. It says in there you need to meet these criteria.
Physician order, so it's not F, but the qualified person definition is in this box on the back.
Right.
It's between F and G, but it's not either one.
So in that sense, your physician has to say, yes, you meet
Yes.
the qualifications, and I'm going to write these orders based on your wishes, particularly